The first half of this class is going to be pretty much review. We're going to go through the slides a little bit quicker. Then the second class that we're going to go over today is going to be pulmonary imaging studies and bronchoscopy. All right, here's my contact info. So, preferred text, you can call or text me after 8. I'm probably not going to answer because I have a newborn at home. Yeah, I just don't sleep. So, you don't get a reply from me, don't think I hate you or anything like that. Just flip bandwidth these days. All right, so we're going to jump into this. Upper airway, lower airway. Pretty much our cutoff. You guys can't see this. So it's going to be the trachea down the vocal cords or the larynx is what we're talking about when we go lower airway. Predominantly, the majority of what we're going to be talking about is lower airway. So the trachea, the bronchi, the lungs. We'll talk a little bit about upper airway stuff as well. And this is just anatomy review. Hopefully you know this by now. Also, if you see that FYI in the corner, unless I tell you differently, this is for your information. It's not, I'm not going to have a diagram on the test if you label the tongue. So that'd be a good 2-point question. All right, so first off, we're going to go into the bronchoscopic view. So we'll talk about bronchs in the next class. But really what I want you to get out of this is right versus left. How can you very easily see the right versus left? The right is more vertical and wider. So we talk about intubation. What's the concern with intubation? Right main stem, right? Can you get in the left main stem? Absolutely, I've seen it. Right main stem is going to be more common though. So for foreign bodies, when you intubate somebody, bougie, it's going to go to the right main stem. Just remember, it's because it's more vertical and wider. It's an important aspect to know about this. All right, so bronchioles, this again, A&P review. Some sympathetic stimulation, you exercising, what happens? Bronchodilate because you need to move more air, oxygenate, increases your cilius, that's why you're coughing up all that stuff when you're running, hacking up loogies. Improves ventilation for more oxygen intake. Parasympathetic at rest, so airway constricts somewhat to those bronchioles because you don't need it as big. And then you have increased mucus production. Important to remember for that. Then down below, you don't have to memorize that in health, but you're going to see these as you go. And that's kind of the reason why we're doing that. Albuterol being the most common medication. We're going to talk about pulmonary. One thing I always make sure my medics always have is albuterol. Right? That's something that can actually save somebody's life with minimal interventions. But it's going to bronchodilate and increase cilia function. But with it being a beta agonist, what do you have to be concerned about? Yeah. So if you have somebody, one of my first patients in Iraq when I graduated PA school was from another battalion. And it was a cook that was having an asthma attack. He never told anybody he had asthma. He's been in the Army like 2 years. And then the other PA decided to go smoke a cigar with the commander and not have his radio on. So I'm sitting there trying to manage this, and we had a nebulizer, we couldn't get an aircraft. So continuous nebulizer for like 2.5 hours before I could get an aircraft to get her to a level 3. So her heart rate was resting around like 130 to 150 for a majority of that time. So at some point, is it a panic attack or is it her having an asthma attack when you're giving that much albuterol? But the other medication you're going to see commonly paired with albuterol is ipratropium. That's a bronchodilation and increased mucus production. So you may see like Combivent, which is another albuterol inhaler combination you can order. Conduction versus respiratory zone, right? This is where all that happens is the alveoli, where all the gas exchange happens. So grape-like structures. Lobes of the lungs. It's important to classify, especially when you're on your imaging or you're describing this in a consult to pulmonary. I hear bronchi in the right upper lobe. I hear wheezes in the left lower lobe. Being able to actually pinpoint that when you're talking with them. So the left lung has 2 lobes, superior and inferior, and the right has 3 lobes. In the chest, so you kind of see how why the left lung has 2 lobes versus 3, make it room for the heart. So this is actually a pretty good picture to have, like, to save for your records later on. The only way you're going to get better at x-rays is by looking them up, right? If you have a nice radiologist, what do they do for you? They give you a positive arrow sign. So like the good radiologist will point to where like the nodule is, and they'll put a little arrow on there. But if you ever have issues with your chest X-rays or anything like that, I would just call radiology and say, hey, do you have a minute to walk me through this? What am I missing? Identify this, and I didn't see it on my first read. But if you're deployed or in an austere environment, maybe a day or two before you get that telemedicine, so you need to actually know how to read these X-rays, chest X-rays. But I look at this and I say, is it appropriate study? Is it actually what I'm looking for? And then does it have everything? So it has all my, has the full lungs. It's got the edges right here. I see the stomach, the diaphragm, I see the spine, the heart. I see all the ribs and the parts of the clavicles. So that is a full chest view. That's good. All right, so ventilation, right? One thing in medicine, people always kind of mix these up, is oxygenation, ventilation. Ventilation is more so, we're talking about the movement of air in and out. That's elimination of CO2 versus oxygenation is moving air in and out, but it's talking about the actual oxygenation that's going on at the alveoli level and is it getting to the tissues. So patient breathes, it's a negative inspiratory force. Breathe in, create a negative pressure, draw the air into the lung, diaphragm flattens. That's active, and then passive is they relax and air is expelled. So all of our ventilators that we use nowadays are positive pressure ventilation. So they're kind of doing the exact opposite of what the human body does. We're pushing air into the lung, whereas naturally we bring the air in, we pull it in. So you guys remember iron lungs? So that was a negative pressure ventilation where you put somebody in the cylinder, draw negative pressure, pull down on the diaphragm, the air would actually go into their lung. You wouldn't have to intubate them. Just another diagram of that. So again, why pulmonary matters so much is because of this gas exchange at the lung level, right? We breathe in oxygen, gets exchanged at the alveoli, the hemoglobin, goes out to the tissue, drops off the O2, picks up CO2, and then we exhale that. Pretty straightforward. Just another illustration. So just remember, with your pulmonary system versus the rest of your body, the artery and the veins are opposite, right? So pulmonary arteries carry the deoxygenated blood versus pulmonary veins carry the oxygenated blood. All right, so here's where we're actually going to start, where it matters. What do we think about this guy right here? What are some things that are kind of standing out to us if we walked over? All right, so positioning, what else?
His ribs.
What's that? Okay, barrel chest, so increased AP diameter. We'll talk more about that.
Retractions.
What's that?
Retractions.
Yeah, he's already on O2, right? So we're all doing it, no matter, like, right, you're going to start clinical core. What's the first thing you do when you see a patient? Yeah, instinctively, it's like your kid comes up to you and they're crying. You immediately start like looking at them to see if they're bleeding, bruising, broken bone, or anything like that. So I do patients, we're automatically looking at them to see are they stable, unstable. This guy, without a video or any words, I would say right now, he looks stable, on the verge of unstable. A few other things that I note out, he's skinny, maybe some intercostal muscles, accessory muscle use right here. Is that oxygen long term? Have you been on that? Did you come in with that? But here's our warning signs. Who here has taken like pediatric advanced life support? What's the thing they talk to you about pulmonary with kids? Just kids in general. Prevent, right? You don't want to actually start treating stuff because by the time the kids compensate, they look like crap. And then you don't put oxygen or start treating, what happens? They crash very quickly. Adults are a little bit more resilient. The children are going to go down very quickly. So those warning signs need to be monitoring on a pediatric patient, especially those. All right, so patterns of breathing, rate, rhythm, you guys know that, right? 12 to 14 breaths per minute. I feel like as an Italian PA, every time my medics did vital signs for me, they were perfect, right? It was like 12 to 16. It was 120 over 80. I don't know if anybody actually ever checked respiratory rate. Usually you can tell the patient's kind of gasping for air or breathing fast. But a normal pattern is what we're going to be focused on. So anything over 20, dyspnea, too small breathing. What do we think? What's like the classic diagnosis for that? that? DKA, right? Diabetic ketoacidosis. What else would you notice with DKA? If you're getting close to them and checking them. Right? Yeah, keep on the sweet breath, right? So if you see patients doing this, it's very deep breaths and they're doing it rapidly. Another thing is COPD patients, air hunger, right? They feel like they're not getting enough air, even though they have a nasal cannula on. Don't tell people I said this, but as an RT, we used to blow a fan at the foot of their bed. Like, I'm gonna help you out with your air hunger. We just put a foot fan down there, blow it towards their face, and they're like, all right, that's better, I'm getting more oxygen. It's really not, but it makes it feel better. All right, change scopes. This is a pretty interesting one, and here in a second I'll show you what it looks like on the waveform. But it's regular apneic episodes with rhythmic breathing. So your tidal volume is going to change throughout that. So it's pretty interesting to see. Throughout this too, there's also some examples, some links you guys can go to if you're interested in this. I think we changed those with high altitude. You guys go up in the mountains. They're doing some operations up there. Where you put somebody in the back of an aircraft, you get them up to altitude, and they start having issues. That may be what you see. And then what's agonal breath? Right? Like that's a very, like, once you see it, you kind of never forget it. Then like 15, 30 seconds later, as a respiratory therapist, I think we used to discontinue life support a lot. Families would come there, I hate to laugh at this, but families would come in there, the patient would be like, all right, they're gone. And then as you be leaving, they let out agonal breath, and the family would like, no, man, it's not good. But sometimes the agonal breath can last for a while, so you see those, you're hearing them. Here's just another example, so you kind of see the waveform of what they would actually look like. See with the tachypnea and Guzman, they're still pretty organized in pattern versus look at the chain scopes. What's going on with that? It's organized, but it's kind of disorganized, right? Not regular breathing. Then agonal breathing, just intermittent breaths pattern. All right, so breath sounds. There's a few slides down. There's links if you want to listen to these. Stridor, what I want you guys to think is some obstruction in that upper airway, right? So croup, epiglottitis, those are going to be like your buzzwords. If a pediatric patient comes in, they have stridor, your mind should start going to a few different things. Croup, epiglottitis, maybe some type of obstruction. And those are usually when you walk into the room, you hear it before you even walk into the room. The kid's pretty loud. You don't need a stethoscope necessarily to hear those. Bronchi. You ever hear like an old smoker talking to you and they clear their throat? That big mucus plug comes up. A lot of times that's what that bronchi sounds like. It's a rattling sound. Wheezes, right? Those may be audible without a stethoscope. Again, your asthma patients, there's cystic fibrosis, but that's going to be the expiratory sound. And then crackles. I always thought crackles is wet. So if they have congestive heart failure, a lot of fluid in the lungs, you're going to hear that crackling, kind of like the Rice Krispie treats. You hear that absent lung sounds. I will say for your phase 2, check your patient's history to make sure they haven't had like an actual lung removed before you put bilateral breath sound clear auscultation. Not saying I've done that, I have done that multiple times. So the doctor afterwards, like on rounds, he's like, how'd that right lung sound? I'm like, oh, it sounded good. I didn't hear anything. He's like, that's cool. Then later on, he's like, he didn't look at me. He'd be like, after the patient had his right lung removed last week, I'm like, oh, shit. So, pro tip is make sure you actually check that before you document bilateral breath sounds. Again, there's, if you want to be a nerd, listen to all these. Tactile primitives. So blue balloon 99 is where you put your hands on both sides of their chest or their back and have them say these words, and then you're going to feel that. I've never been successful in actually doing that, to be honest with you, but it's something. And then E, the same thing right here is where you're auscultating them, have them say E. If the consolidation, then pneumonia, you may hear a little bit more pronounced. This is just an example of how you would do it. All right, pulmonary signs. So cyanosis. What else could this indicate besides cyanosis? What's that? Raynaud's, right? Cold hands. You see people in the field. Like, your hands all right? They're like, yeah, I'm good. You can help out with their VA disability by documenting Raynaud's. But cold hand, it would have to be pretty pronounced extreme anemia to get that type of cyanosis, but it's possible. All right, clubbing of the digits. This is pretty specific for COPD. Although you are going to see patients that just have clubbing of the digits. What's after working around a lot of COPD patients, chronic obstructive pulmonary disorders, and smokers. I started seeing this every time I went to the grocery store, I went to the bank or anything. I started judging everybody. These quit smoking. Yeah, clubbing of the digits. But it's pretty. The one on the right is not quite as significant, but on the left you can see how that looks like a clubbing. So edema, right? What else could you see with this? What other disorders? CHF, right? But you see on the left, that's actually what we're looking for, is that kind of that thumbprint sign. When you push your finger in, they can just be back and poke it, pokes right back out. With peripheral edema, it's going to be stagnant like that for a while. All right, so this guy's a veteran. What do we note about that? Just that yellow, right? Around his lips where the smokes, all good stuff. Right. So that's the first class. Any questions? All right, we're going to go to pulmonary imaging and bronchoscopy. All right, so by far in primary care, the most common study you're going to order is a chest X-ray. It's going to be PA lateral. So you can also do bedside, which is not very good if you just think about how they're laying down and how that's going to distort their anatomy, maybe fluid. But by and far for pulmonary, PA lateral chest is going to be what you're ordering. But it's a good, quick test to show you pneumonias, infiltrates, hemasses in the thorax. I can tell you, I count on one hand in 15 years as a primary care PA that I ever ordered MRIs. Typically, that was at the direction of pulmonary, like for very specific things. Hey, go ahead and order an MRI. CT is going to be a study of choice if you're trying to evaluate some nodule that you find on chest X-ray. And that's going to happen to you where you just like crap. Somebody comes in, they got like a routine chest X-ray for some type of physical for some school, or dive school, or airborne, or whatever. They're going to come back with some type of nodule, and they can't be cleared until you have an answer. So, chest CT is typically what you're going to order for that. And then you do a CT angiogram if you're trying to evaluate for pulmonary embolism. And again, MRI. Majority of the times I've ordered it for pulmonary stuff was at the direction of the pulmonologist or internal medicine, and it was for some type of malignancy that we were trying to evaluate further. You guys already had your radiology class? Okay. So, a few things you can read through this. The big things I want you to pick out of this is going to be diffuse. So, if I give you a patient scenario where chest X-rays order and there's diffuse infiltrates around it, think viral or atypical pneumonia, right? For diffuse findings on a chest X-ray. If I see lobar, right, it's isolated to a specific lobe that's more indicative of bacterial pneumonia. Those are two big things I want you to pick up out of this slide. But it helps you a lot. So if you order a chest X-ray, the more specific you can be to that person you're consulting with, telemedicine, or calling a specialist. You can say, hey, I have diffuse findings in the right upper lobe, or blah, blah, blah. That's what they want to hear. And then if you can tell them if it's perihilar near the central hilum, right, is it in the center, or is it multifocal? A lot of examples. Let me get the light. That's a little bit clearer. Yeah, I can hold it. Good enough. So, this one on the left, what am I looking at right here that's coming out? These are your lungs, right? This is your trachea, this is your carina right here. You see that dark line? What's this guy right here? Yeah, the tracheal tube. And these are just some leads for what we're seeing. What we're looking at is all these infiltrates all throughout that diffuse pattern, right? This is more indicative of viral pneumonia, possibly some type of pulmonary edema. Versus lobar, right? Very clear and concise if you were describing this to somebody over the phone or in the consult that you're writing, saying, hey, consolidation in the right upper lobe, right? See that clear fissure right there? So very high to the right, we're seeing all this right here. What could this be? Okay. Aspiration pneumonia, you typically see it in the upper lobes, but you could see that there. It could be just incidental findings. It could be some type of inflammatory process. It could be an infection. Multifocal, right? So you see all these clear, distinct masses. These are all lung cancers that have metastasized. So it may not be primary lung cancer. It may have been somewhere else. Metastasized to the lungs. You see all these. At our level in primary care, you wouldn't need to describe each individual one. You would just say multiple consolidations, unknown masses, bilateral lungs ranging in size from 2 centimeters to 5 centimeters, right? And when you pull up these x-rays digitally, you'll have like little measuring tools and everything on there. And then here you're seeing that too, multifocal pneumonia. So what is this? Think it's bacterial? Or viral, fungal, it could be bacterial, but most likely it's going to be viral. All right, ultrasound's a new hotness. Everybody use ultrasound? All right, so your senior block, you guys are going to get a lot more use with it in your ER class. You guys will learn how to do screen for these. The only way to get good at ultrasound is to do a lot of it, right? So if you're in the clinic, use chest x-ray. If you're deployed, austere environment, you use ultrasound, but I wouldn't hang my hat on it if I have other screening tools necessary. Just because it's not going to be the standard of care. If you're going to get a lawsuit, they may come back at you with that. But pulmonary edema, you're going to see the lines come through. Pneumothorax is very good for that, especially ER, aid station type of environment. All right, PQ scan. Really, the only time you're going to use this is for PEs. There are some other identifications why you would use it, but it'd be more so at the specialist level that they would order it. It's a good study. We do it. It's the gold standard for PEs, but it's not very commonly done because it is a little bit more time intensive. Some patients can't do it. Like what patient couldn't get a CT angiogram? Pregnant, contrast allergy, right? So those are your two most common. That's why you would order the PQ scan. So essentially, they inject a dye into them, and then they have them breathe in a dye, and then you compare contrast to see if there's any change in the ventilation versus perfusion. Ventilation is basically the gas is going into the lungs. Perfusion is the blood actually going into the tissues. We have pictures in another class that we'll go over to show that more pulmonary. Bronchoscopy, right? There's really not a common reason why you do this in pulmonary, or in primary care. You may use this in the ER, but good diagnostic and treatment tool. Very rarely do you ever see the rigid bronchoscopies. They're typically flexible, so that you can go down further into the bronchioles. But it has a lot of examples, these ports on there. So you can collect samples, you can do a biopsy. It has a little cautery in there, it has little graspers. You can do lavaging, so if you're trying to get diagnosis, or with like a burn patient has ventilation injury, you have a lot of sloughed off tissue, you can actually lavage it and then suction it out to clear out their lungs. So, but it'll also help you with certain types of cancers. So, most common, it's going to be used for foreign body removal. Might want to remember that. All right, so this is looking down. right here, where's one, is this the right or left? Right, so yeah, if you can see into it, most likely the right, more vertical, wider. And then this is lung cancer. Do you think this patient is asymptomatic or symptomatic?
Symptomatic.
Yeah, so this is like very advanced lung cancer. This is somebody with like out insurance is homeless who finally collapses and they call an ambulance and they bring him to the ER, this type thing, or somebody who is on hospice, terminal, and they're in stage, this may be what it looks like. All right, any questions? All right, do that. All right, you guys are done for the day, unless you guys either have anything for you. I will be doing a review too, before your test, so don't worry. But I need some of y'all like this, if you don't get some of you 100.
Don't worry though.